Well, welcome everyone to this session. I'm Deb Adler. I'm the CEO and founder of Navigator, and I'm delighted to be moderating this session. The topic is meeting people where they're at with telehealth substance use disorder treatment. So meeting people where you are, where they are, where they're at is something that is near and dear to my heart. Navigator works with payers and employers to help their members get fast access to evidence-based substance use treatment, and this is one of our mottos, that and delivering knowledge with hope. So we have independently licensed clinicians who do motivational interviewing, and if you're familiar with that, that's really the focus, right, is meeting the individual where they are and helping them commit and engage in treatment. I'm going to have the panelists actually introduce themselves, but I'm thrilled to have really a variety of folks from the payer land, the provider land, another payer, and then I guess you would call yourself an ACO, would you call it? Okay. But before I introduce them, I know this is sponsored by the Work It team, and I know I was asked to have some of the Work It team members stand up if you have any questions afterwards. Okay, there's the Work It team. And I know the Work It team well. We have a platform and we onboard providers to offer that fast access, and Work It is one of our providers as well. So let me just have each person just introduce who they are and what they do, and then we'll start in with some questions. Maybe Allie?
Great. Hi, everyone. My name is Allie Haight. I am a licensed clinical social worker, and I work at Oak Street Health, which is an organization that provides primary care services to individuals on Medicare. We are a fully integrated primary care clinic, so we have behavioral health as a part of our care model integrated into our centers. So really working to bring people into the treatment of behavioral health and substance use disorders, increase that access for our patients, and just be able to further prove that mental health care is health care. So really having that be at our core of you come to the primary care doc, not only can you get your physical health needs met, but you can also get your mental health needs met.
Thank you.
Hello, I'm Stephanie Stitt. I'm the Director of Behavioral Health for a Medicaid plan called CareSource, based out of Ohio. CareSource covers about 55% of the Medicaid lives in Ohio, so around 1.5 million individuals, largest MCO in the state, and the plan that really drives the behavioral health work that is happening throughout the state. So very excited to be here. Prior to this, similarly, licensed independent social worker, working at Groups Recover Together, who is a tech startup SUD treatment provider. So excited to talk about this topic.
Hey everybody, my name is Justin Coffey. I'm a psychiatrist by training, but don't hold that against me. I'm the Chief Medical Officer at Work It Health and a Professor of Psychiatry at Geisinger School of Medicine. Delighted to be here with you all, especially because I'm a big fan of all things Deb Adler.
Me too. I'm Rachel Goldberg, so happy to be here. I'm responsible for strategic partnerships and product innovation for Horizon Blue Cross Blue Shield in New Jersey and for Novawell. Novawell is a spinoff of Horizon Behavioral Health that we launched about 2 years ago with the intent of helping other health plans to expedite their own behavioral health strategies. So it's fun to go from payer world to startup world to kind of in between payer world, and thank you for having me.
Great. All right, well, we're going to kick it off with some questions right around the actual topic, meeting people where they're at. Is that good English? I used to be an English teacher. I don't think you're supposed to end a sentence with a preposition, but anyway, meeting people where they are. And I'm really curious, Allie, because since you're in a PCP integrated setting, how do you help people meet them where they are, and especially around substance use? Do you do screening? How do you deliver the care to help identify and get the right people where they need?
Yeah, absolutely. So when I think of meeting individuals where they are, I think of kind of three main things that we prioritize at Oak Street. The first being just identifying those individuals who need services that come in. So we do a lot of screening. We screen early and we screen often. So our PCPs are regularly screening individuals for any substance use concerns that they might have, any problematic behaviors, anything like that that would kind of warrant further treatment. And then we have our in-house behavioral health team that can kind of jump in and provide those services once the need is identified. So it allows us, to be able to capture those individuals who might not be actively seeking services necessarily, but we are able to, again, intervene early, start that conversation early, and then really let the patient kind of direct where we need to go in terms of if they're ready for services now, we can get that set up. If they are not, we can continue to kind of monitor through those screener questionnaires. The other thing that we do within our model, once somebody is linked up with our behavioral health program, is we utilize the collaborative care model in terms of treatment. And one of the principles of the collaborative care model is a change in treatment plan every 4 to 6 weeks if we are not seeing the clinically significant drop in those screener questionnaires that we would hope to see in that time. So we are really tailoring treatment towards that individual, talking with that individual, having them be an active part of their care so that we can identify any barriers that maybe we weren't aware of in the beginning and adjust that treatment plan, adjust the interventions and the services that we are providing in order to meet them where they are at that moment. So even individuals who are engaged in services, we are still constantly kind of identifying where they are. The last thing that I think of in terms of meeting people where they are is recognizing that stigma is a thing, and that also can keep a lot of people from engaging in services or seeking out services, particularly for substance use disorders. So at Oak Street, we are very integrated. That is, our whole model is integrated care and really, like I said earlier, making mental health care and substance use disorder treatment a part of general health care. So we are having those conversations often, openly. It's not a uncomfortable topic for us to talk to patients about. We are really making it a normal part of the process so that when people think primary care, they also think mental health care. So kind of meeting them and again, kind of knowing what's going on with that individual, developing that relationship with them, developing the rapport, having those open conversations regularly, in addition to screening, identifying those needs, even before the patient might verbalize that they are seeking those types of services.
That's really awesome because I often hear that PCPs don't want to discuss substance use disorder and that most people don't share that information with their PCP. Did you do any special training for the PCPs or particular screening instruments? I'm just curious because, you've come way farther than a lot of other organizations. I'm just curious.
Yeah, that's a great question, and that is an ongoing process. Love our PCPs, very much do. But yeah, that's something that we regularly talk about as a leadership team as well. I am a lead behavioral health specialist, so a lot of my role at Oak Street specifically is doing the training, overseeing the clinics, overseeing the individual behavioral health specialists on the ground, providing those services. And so we do regularly have trainings for our providers as refreshers, especially if we have a new behavioral health specialist coming on board, and this might be the first time that they have had a BHS listed or located in the center. We do a lot of internal training around how to utilize them, how we can best serve our populations with the resources that we have.
That's great. So they're co-located and just part of the team.
Yeah, so we are in the clinic, and we operate in a very integrated model. So there are lots of times where we will see a patient that they're there for a primary care doctor visit. The doctor can literally poke their head out and say, hey, can somebody grab the behavioral health specialist? And we can scoot right on in and introduce our program and kind of get that person involved right in that moment, even though they weren't here for behavioral health potentially, but we're able to identify those needs and really work together in the moment to get that patient in services as quickly as possible and kind of strike when the iron is hot.
That's great. That's great. I'm going to turn to Stephanie and ask some questions about social determinants of health. I know at Navigator we try to pay attention to that, ask questions about do they need transportation, childcare, but tell me what you're doing at CareSource to understand the social drivers and how you work to mitigate those to help people get care.
Yeah, absolutely. So annually, we are refreshing our behavioral health strategy. So we do that through data. So we're able to see a lot of data through claims and through other avenues, as well as voice of the customer. So we have a platform that's called The Circle. I always refer to it kind of like a Facebook group. So we have 5,000 members that opt to join in, and it's a way to interact with other members, to directly interact with CareSource. There are different articles and different things that go out, but we can also send out surveys. So we can hone in a survey based on a diagnosis, based on a population, based on location where they live. So we're able to get really in-depth voice of the customer from our members. In addition, these are members that are, again, choosing to engage in this platform, so they are giving us a wealth of knowledge, because that's what they're really signing up to do. And then, of course, voice of the customer from our providers. So learning from our providers where are the gaps and where are they seeing those needs. So then what do we do with that? So for BH, we have a very in-depth strategy that focuses on a variety of priority populations. And then we implement different innovations and interventions with our providers. So for example, we heard from directly from a member who reached out to their care manager and said, hey, I can't get to the methadone clinic every morning. It's not happening. And transportation is hard. I'm trying to use transportation through CareSource, and sometimes it's there, sometimes it's not. I can't do it, it's too hard. So we partnered with Telehealth, who is a company that is very much like a lot of the providers and companies here that allows for take-home methadone. So take-home methadone has been this taboo. You can't do that, that's not okay. And Telehealth allows for individuals to take home methadone in a non-tamper-proof medication bottle. They have an app that records them taking it, and then what's really fascinating is that then the nurse can watch it in hyperspeed, so they're able to reduce what is usually a 7-minute interaction for a nurse and a patient down to 3 minutes or less. So it's also helping enforce the workforce as well. As a whole, CareSource launched not a service, I guess a service called Life Services. And so Life Services is around SDOH. So that any member 14 years or older, or any individual in a household of a member of CareSource can access Life Services. And so they are given a life coach, and they work through all the SDOH, transportation, employment, housing. In the last year, the life coaches have helped over 100 of our members become CDCAs, and then physically take them to employment fairs. They role play interviewing. So that is the whole concept of Life Services. We're working to also implement a process for them to become STNAs and different things like that. So Life Services is not a contractual requirement. It is not reimbursed by the state. It is something that CareSource does because we care and we want to help break down any barriers that individuals are facing.
It makes me miss Medicaid. Just Medicaid always seems to be more innovative and out in front, and that's just remarkable work. I'm thinking when you started describing the Facebook-like program, I was thinking back to a payer that was just beginning to have the providers put Z codes on the claim, which was a start, but you were really taking it to another level. That's awesome. Dr. Coffey, I want to talk a little bit about special populations. When I think of substance use disorder, it's a complex chronic condition, and usually there's not just one need. Sometimes there's not just one substance. We have adolescents, all kinds of different populations, perinatal needs. Tell me how work is managing those special populations.
Thanks for that great question. I think that the population that we serve is already vulnerable It's already stigmatized. And then you've got these cohorts of folks within the population that have extra needs or kind of specific kinds of needs. And one of the things that we talk a lot about at work, it's really our mantra, is patients as designers. So we start with the care that's grounded in science and the evidence, and then we bring people with lived experience to the design table. And we ask them, not people like me, we ask them, how would you want this care to be delivered? And if you stop and think about that concept for a second, it's really quite profound. And I mean, I think it's the way all healthcare should be designed and delivered, quite frankly, whether it's SUD care or anything else. And so what that looks like is populations like, let's take individuals who are pregnant or trying to become pregnant. When you think about how they would design SUD care, initially it's pretty demoralizing because the bar is so low. At work, one of the first things people came up with was, well, hey, let's not just kick them out of the program. Let's not have pregnancy as an exclusion criteria, which is commonplace. And I don't mean to be critical at all. I've led and overseen clinics where we had that exclusion criteria. But the first thing is to welcome them and to understand that we are guests in their lives during a very, very important time. And if you really can take that approach, and if you've got people with lived experience at every level of your organization helping make design and redesign decisions, the outcomes speak for themselves. So we have peer-reviewed published data, for example, in the population of individuals with opioid use disorder who are pregnant or were trying to become pregnant. Roughly 2/3 of folks actually in our analysis were not pregnant when they started treatment, but became pregnant once they were in care. And the other third to 40%, were pregnant at the time. So the first thing is welcome them. Meeting them where they are means don't say you're not welcome here. The second thing is to really double down on every aspect of the experience of that care. So how can we, for example, take something like a urine drug screen, which has for decades been an incredibly integral part of the experience of receiving substance use disorder care. In a lot of ways, it's shame-based, it's kind of punitive, or it's a tool for accountability. And we've got some incredible developers that figured out a way to make this actually one of the most satisfying parts of the work experience. We've got a couple of different ways that individuals can do urine drug screens using their smartphone. Entirely scientifically valid, incredibly convenient. They do it in the comfort of their own home or at work or in their car, wherever it makes sense for them, literally meeting them where they are. And that's something that doesn't apply only to the perinatal population, but to everybody. And the last thing I'll say is really that the thing that we hear over and over and over again from our members is, the condition that we're trying to work with them to treat is something that, by definition almost, it can compromise or be an obstacle to the individual's efforts to engage in recovery. And so the delivery system has to be there at the moment when the individual's ready to begin their recovery journey. And so, is it something I said? Yeah, so I think when I was in academic medicine for many years, we would have, pizza parties when we got our wait list down from 120 days to 90 days. And I don't mean to minimize that, but, WorkIt's designed its delivery system so that someone can download our app in 3 minutes or so, sign up for their first appointment, and be seen the same day or next day. In fact, most people are so surprised that they could be seen the same day that they're not ready for that, and they choose to be seen in the second day. But just making that the priority for the delivery system for us is a really powerful example of meeting people where they are, including some of the especially vulnerable populations.
you said so many things that just resonate, but this is the first time I've heard the word satisfactory in the same sentence as urine drug screen. So that alone was a quote I'm going to remember. I think, and also the importance of in the moment, right? And you said it too, strike when the iron's hot. That's what we try to do at Navigator, right? While the person's on the call, let's get you scheduled now. And same reaction, like, what? Now? But often it's also delight. Like, I made this call for a reason. And so it's just great to hear that person-centered design. You hear it, the phrase a lot, but to live it in action is just really, really neat. I'm going to turn now to talk a little bit about value-based contracting. And I always think of substance use as really the one diagnosis or condition where I think the payers are further along, right? It was one of the first areas where we saw bundled payments or other alternative payment models. So I'm curious, Rachel, what is Horizon doing in this space around value-based contracting, particularly for substance use disorder? Do you have key measures, criteria to participate? And the whole point is outcomes, so what are you finding?
Yeah, absolutely. So I joined the Horizon team in 2017 with the intent of trying to make New Jersey healthier. We were not trying to create a new company at the time. And we started searching for different types of evidence-based substance use disorder treatment because we had a large network in New Jersey, lots of prescribers who had the waiver to prescribe, and no one was using it. And we made, lots of attempts out to the network to say, we see that you have the waiver, why aren't you prescribing? And we just couldn't, even incentivize anybody to use it. So we started looking around the country, and that's how we ended up finding some of the more innovative solutions that we partnered with. And at the time, we knew that the only way to really make a collaborative relationship with these new organizations like WorkIt was to figure out a different type of payment structure to support these organizations to really provide anything that was required to make the member better, and in a way that sort of got rid of this perverse fee-for-service cycle that was, not necessarily helping to fund outcomes. So that's how we began. And then over time started to look into new opportunities with the local network. So in New Jersey in 2019, we started an initiative with CCBHC's Certified Community Behavioral Health Clinics, who historically supported the Medicaid line of business, but had not really ever had the opportunity to work for commercial payers. And we started integrating them with our large major health systems. And at the time, and again, it's funny, we talked about this morning, there's so many different definitions of like what value-based care actually is, so it's sort of what you make of it. But at the time, these CCBHCs needed incentive payments in order to actually get up and running, to have the infrastructure to take care of commercial payers, and we provided them with that. And then things have sort of changed over the course of time, like standardized metrics across the network, like trying to incentivize for better outcomes, sort of monitoring organizations across the board to see really who is getting people in quickly. But aside from getting people in quickly, is the clinical care that they're delivering based in evidence, and are they actually fulfilling their mission to get people better? So if it's an organization that says they're focused on MAT and all corresponding services, how do you do that, and does it actually prove out in the long run? And then over now, it's been so many years since we originally started our relationships with these companies, but continuous monitoring on the back end, not only to look at clinical progress, but also to sort of evaluate what has happened to the trajectory of that member since they started in treatment. And it's been really exciting consistently over the course of time. We've seen that patients who have been part of these different solutions have had, decreased use of emergency room, decreased use of higher levels of care, adherence to medication and care plans, all of the things that we wished and hoped for in 2017 when we were starting this. And it, proves that if you change the sort of relationship with the provider organization and enable them to fulfill what it is they say they will, more often than not, it works out. So, that's great.
I just want to appreciate that comment, because the conversation with payers when it begins with, well, what's the evidence and what are your outcomes, is so powerful. It just represents a completely different experience than the provider side has had for decades. And I will say the provider side, has a lot of work to do to get up to speed with demonstrating outcomes, right? And so when you've got a payer like your team and then you've got a provider like Work It saying, we're proud of our outcomes. We know we have a lot more work, to do, but we'd love to share our outcomes with you. And by the way, don't take our word for it. We have peer-reviewed outcomes, right, in the published literature to share with you. Then the conversation, right, it just is so different, and it's much more productive, kind of based on some of the conversations that were happening in the value-based care conversation this morning.
I'm curious, are there any particular metrics that you've honed in on? I think you mentioned reduced emergency room use and I guess community tenure. I'm just curious about any metrics specifically, because I know the provider audience wants to know what are those important measures, and then I'm also curious about the use of peers, right? Individuals with lived experience, and always loved that it was reimbursed often in the Medicaid setting, and then terribly disappointed that it isn't in the commercial setting. How often? However, certainly that's part of the notion behind bundled payment, right, is to incorporate it. So 2 more follow-ups for you, Rachel.
I appreciate you jogging my memory. I should have said those things at the offset. So back to the piece about peers. So we think that, the relationship with someone with lived experience is such a phenomenal way to keep somebody on their journey. And that was actually one of the original reasons why we started doing these bundled payments, was to figure out, how do you pay for digital services that have no corresponding codes? How do you pay for peer support, which at the time was not reimbursed by commercial insurers? And as a way to sort of lump everything together and really give the autonomy back to the provider organization to do, whatever it was that they needed to do. And we felt the same way with the CCBHCs. At one point we were like, here are, your additional funds, use them as you will, take someone to an appointment, take them potentially to a yoga class, if that's what's going to help that particular person get better. And then we've launched some separate peer programs over the course of time, both in the mental health space and the substance use disorder space. Because again, just like how if you had a physical health condition, it's always important to sort of follow the journey of a human who's been there. I'm sorry, Deb, I have a short memory, and you need to tell me your first question again.
That's okay. Although it's interesting to hear a payer mention yoga, because I always tell...
No, there's no CPT code. You absolutely cannot pay for it. We will not pay for it if it's separate.
I know. The other question was metrics, in fact, because I always...
important.
I'll let you answer. And
No,
then
sure.
I'll follow on.
So the panel this morning talked about value-based care going from like kindergarten level to college-based level, and unfortunately, we talked about this morning, there is no set standard, although I think everybody in this room agrees that we would all like to wrap arms around and push toward a standard. So at the very sort of basic level, the things that we monitor are how quick, number one, do you work in an evidence-based way, and do you make your providers have, fidelity to the model that you are pushing? How quickly can you get somebody in? Are your members satisfied with their care? Are you trying to, again, fulfill the evidence base of things like medication-assisted treatment and corresponding therapy, not just one or the other, although certainly everyone has an independent journey to get better. Satisfaction both on the provider side and on the member side. If you have providers who are not happy in their work, it's very hard to get them to help members to feel better. And then way more longitudinally, we look at things like adjustments in higher levels of care, shifts in out-of-network utilization to in-network utilization, and things like that.
I think there's, if we were talking about the cancer space right now, there's lots of different ways to measure the outcomes of cancer care. And I don't hear conversations about the fact that there are so many different measures as a barrier to some sort of progress. I think in the behavioral health space, the clinical side has been dragging its feet to actually measure anything, which is a big problem. I think if you can get over that and you really focus on, I think, what we all want, which is whatever the outcomes are that matter most to the people that we serve. And so at work, we do the usual kind of process measure and screening measure stuff too, but we also have a unifying substance use measure, which is the SURE, the Substance Use Recovery Evaluator, which is University College London, I think. It's one of the only scientifically validated outcome measures for all substance use disorders that was actually designed in collaboration with people with lived experience. So all of the language is health behavior oriented, recovery oriented, rather than symptom or deficit oriented, which is terrific. And it also has multiple dimensions, only one of which is alcohol and drug use, right? The symptom that the white-coated people are trying to treat. The rest are functional domains. So how are your relationships? How is your professional, occupational, vocational work going? And it's amazing when you can see substance use either going down or maybe even staying flat, but functional outcomes improving, how powerful that is, not only to sort of really demonstrate, okay, here's value being generated at the point of care, and here's something that means something to the people that we're serving. And we can discuss those measures, with a lot of interaction and kind of revisiting, because, sometimes they go up and sometimes they go down with the vicissitudes of life. But you've got a shared language, all of which is recovery-oriented language.
I hadn't heard of the SURE. That's really neat. I think back to the MISSA back in the day was the one that was recovery-oriented. That's great to hear. While we're on the subject of metrics, I'm curious, Stephanie, at CareSource, are there any particular metrics you're looking at, or value-based payment?
Yeah, it's really interesting to hear, and what I keep thinking about is burden on the providers. So the metrics that we're looking at are very different than what a commercial plan is looking at, and the metrics that CareSource might be looking at might be different than what Humana or UHC is looking at in Ohio. And so that takes us back to, in case you were wondering, there's a workforce shortage. And it's a joke that we have at CareSource because you hear it all the time. And so to that point, the metrics that we primarily focus on are around HEDIS. And HEDIS metrics are, that's what the state looks at. That's what quality withholds are wrapped around. That's what our financial stability is wrapped around. And they're critical. But the metrics you guys are talking about, and it's always so interesting, it takes me back to my provider days, are the metrics that the providers bring to us to say, like, hey, we're really amazing, we're doing great work, which they are, don't translate over to the metrics that we are focused on and that we're required to be focused on. And so it's finding a way, how do we bring together what the providers are focused on, what commercial is focused on, what Medicaid is focused on, but like, what does the member need and how can we do that? So all of that, to answer your question, is we are primarily focused on HEDIS metrics based around either what we're seeing throughout the data collection, voice of the customer, or again with the state ODM, Ohio Department of Medicaid, is pushing us to focus on. So this year we did a lot of focus of collective impact with the other plans around the antipsychotic metabolic monitoring. So kiddos on 2 or more antipsychotics needing their labs completed, and now rolling into collective impact around FUA. So focus on adults and follow-up care for them.
Follow-up after hospital and emergency
Yes.
room. And how about the dreaded IET, initiation and engagement?
So that one
Treatment?
actually is one that I think is really critical. That's like, how fast are you getting folks in, right? It's how do you be proactive? And when we talk about metrics, it's usually reactive. It's like, okay, how can we get ahead and not be so reactive? So as we are building out our behavioral health, BBC, APM, whatever you want to call it, that model, in that we have IET for our SUD providers. And so we have 4 different population streams that we build our APMs around. And then within that, based on the provider, it's customized even further for them. So IET is one that is in the APMs, BBCs, for our SUD providers. But I think
LMNOP.
I know, right? I think you're probably also laughing a little bit, is that these metrics are really hard to decipher. One, it's hard to get the data in general, even though it's right at our fingertips. They're just challenging, and then to decipher it, and then to take that to figure out, okay, how can we help improve it? It's not a simple process.
No, it's very interesting. It did sound like alphabet soup.
does,
Yeah, the
it
alternative
does.
payment model, APM,
Yes.
and IET, initiation, engagement, and treatment. But I want to give folks in the audience a chance to ask questions. You can either use the QR code, or you can step up to the mic and offer a question as well. Oh, is this a quiet audience? Oh my goodness. Okay. Well, I know I will have more questions for this group. I guess while the audience is thinking if they have any questions, I'm just curious. It's funny because when we were chatting ahead of time, weeks before the conference, we were talking about all the barriers and all the challenges, but I didn't feel like this was a downer. I think everyone was talking about, how they're improving the system. So I'm curious if for each of you, if you had, the magic wand and could make a difference in the system, is there a particular area that you think needs more attention, or that you would want to hone in on? And we can go in any order. If there's
Don't get us started.
Right, I can start. Yeah. So I am particularly excited about primary care being more integrated and involved in behavioral health and substance use treatment. I think that there's a lot of evidence that shows that usually primary care docs are the first ones to know about these concerns that the patient has, right? It's the first kind of stop for a lot of patients, but for some patients it's the only stop. They don't have access to those external specialists, or there might not be any agencies in the community that they can go to and explore services that way. So with the kind of changes in like the DEAX waiver being lifted, and just having more providers that are able to provide these services and prescribe these medications, I think that opens up a huge door for our primary care doctors and our general healthcare system to be able to provide these services that we know are so needed in communities.
Question?
Can you follow up with how you think that change management process can happen? And having seen a lot of resistance from primary care providers, what are you seeing as a successful way to actually make that, get providers over the hump there?
Yeah, that's a great question, and that's something that we have run into a lot at Oak Street specific, right? Like we have, currently we have a small handful of centers that provide medication-assisted treatment to our patients in center, where they have a medical provider that we primarily utilize Suboxone, but have that in center. They come, they meet with our behavioral health team, they meet with the medical provider, they get their medication, and they're good to go. Very, very, very small number, unfortunately. Talking about kind of waving a magic wand, if I want to be selfish towards Oak Street, my waving a magic wand would be every single Oak Street medical provider providing medication-assisted treatment. But we know that that's a barrier, that a lot of primary care doctors aren't comfortable prescribing those types of medications or managing them. And so how we've done it at Oak Street actually is partnering with our friends at Work It to be able to provide some of those services and continue to increase that access, have those services, even if the individual medical providers are not able to prescribe that or not, comfortable prescribing those themselves. So I think that continuing to have, agencies like Work It, and various other agencies in the substance use disorder space that we are able to partner with and have those services. At the bottom, end of the day, bottom line is we want patients to have access to services, and we want people to get better. We want them to have treatment. However we do that, is kind of, I feel like, how we should be driving our decision making and services. But that is a hurdle, that I think in general healthcare, still exists, and unfortunately will probably continue to exist.
And to piggyback off of that, it's so funny, on a panel last week, I was asked the same exact question, but it was around value-based contracts. But it's the same answer. It's taking that a step further and to integrated EMRs. How do we communicate with each other? Because if the primary care maybe they aren't comfortable with it. That's okay. And we'll get them there someday. But if they could at least see what's going on, or if the behavioral health provider could see what's going on and the impact that that could make, that's a huge barrier from provider standpoint, from an MCO standpoint, from a data standpoint, from a VPC standpoint, is how do we create a platform or a space where this information can be shared. When we were doing the APM, antipsychotic metabolic monitoring, collective impact, that's what we learned. It was not consistent who was prescribing these antipsychotics. It was not consistent who felt that they were responsible to order the labs. It was not consistent on who felt they were responsible to do the follow-up after the lab results came back. And of course, everybody was pointing their finger at somebody else. So if there was a platform that could at least talk to each other, that could help with so many different things.
That reminds me, there's a great piece in the New England Journal of Medicine called "The Not My Problem Problem," and you should check it out. It'd be fun. If I'm only limited to 3 things that I would request, so you got it. Number 1, the DEA needs to fish or cut bait. And the field needs to be able to prescribe controlled substances virtually the way that they've been doing very safely and effectively ever since the COVID era flexibilities were created. Easy, should be easy, should be easy. Number 2, payers just need to start paying what they pay for the general medical side of services. So I wish that we didn't need to legislate mental health parity, but now we need to legislate holding payers accountable for parity. So that's the second thing I would probably change. And the third thing is, I think I would eliminate all of the confidentiality legal barriers to information and data sharing. If you ask individuals with appropriate protections, almost everybody in this country is happy to have their de-identified health information shared and used for improvement processes and purposes. And so it's so hard for organizations like WorkIt to figure out in a quantitative, rigorous way, are we actually bending the cost curve or not? And a lot of it comes down to, you've got a payer who's willing to partner with you, you've got a provider who's willing to partner, but there are confidentiality concerns in the middle of that data sharing, and if too many attorneys get involved, there isn't any sharing. Is that 3 minutes?
Yes, good.
Great.
Mine is extremely Pollyanna-ish, but I would aim to remove all stigma related to substance use disorder. We all professionally, I'm sure personally as well, either with friends or family members or our own challenges, have had our own needs related to substance use disorder or alcohol use disorder. It is extremely common. We all have to make sure that we are not thinking of these illnesses as anything other than that. And that creates large challenges related to how care is integrated, how care is delivered, ensuring that primary care can step up and support patients, but also knowing that patients too don't have to be afraid to ask for help, and that they don't have to be afraid that they'll be treated differently because they are asking for help. So that would be my thing. I also, to sort of piggyback off of the same comment, there are so many media misconceptions about when is the right time to actually get help and how sick you have to become, and I wish that were not a thing, and that proactive preventive care was a more common step.
Hear, hear. Yes, we know most individuals enter care through a crisis in this space, so that. Well, I really appreciate my panelists, but what great information. I think they'll probably stay up here for a few minutes if you have questions afterwards, but thank you all for coming.